Great. So for our first exercise, we're going to try and a little bit push um, our paradigm from this competence idea to entrustment. And to do that, I just want to talk quickly about how we judge competence. Because even within competence, we have not quite moved on as much as we were supposed to. So, for example, when we're talking about assessment, and we're just talking about competence, we would say, well, what is the criteria to decide that this person is competent in terms of what I've just observed? So what we're not supposed to do, and you will not find that anymore in any of the assessment recommendations, is the so-called 50% cut score. So saying that if you've got more than half these questions correct, you are therefore competent in that particular activity or procedure is obviously a complete farce, including our OSCE assessments. But I know an undergraduate level, there's still a lot of using a 50% cut score in terms of deciding whether this is a pass or fail for competency. So when we're talking about competency outcomes, we can't use the 50% cut score. It makes no sense. So then they brought in this concept of standard setting, where you will decide what is the passing standard. And it's quite a qualitative description of what do we expect to be an acceptable level of performance for this person to pass. So again, if you're thinking in terms of an OSCE, if I'm in this station and now I'm doing a station on the respiratory examination, for example, what level would I expect for this person to be considered competent? And obviously, we're not expecting a 90% or 100%, but actually maybe 50% is also not adequate. So actually, how do I score an OSCE, for example, to decide on a level of competence? When we set standards, they are always subjective, which is not a bad thing. And they're expert determined. And what I mean with subjective is that there's an understanding for expertise in the field that we look at it and we go, this is what we consider acceptable standard. It's not something that gets determined by a number on a test score. And the question we ask, and you can see again, safety is in there. Even for competence, we would talk about how good is good enough for this person to be safe to continue doing this procedure. So there's different kinds of standard settings. So norm reference is what I'm using for the diploma of HIV management. Because we've got so many people writing the exam, I can actually decide, okay, great. This gives me an idea of how difficult or how easy my exam is. I can use some fancy statistics and will tell me at which percentage I need to make my pass rate for that particular exam, depending on how the whole group is performed. So that's norm referenced. But criterion reference, especially when we start talking about things like OSCEs and WBA, becomes much more important because then it doesn't matter on how the group performs. So a driving test is a good example. So when you're going for a driving test and they, going around the suburbs or whatever, they will want to see a certain level of competence for you to be able to pass that test. It doesn't matter how the rest of the country is doing in that driving test at that time. And so we have a very strong push within medicine to look at criterion reference standard setting, especially for our practical exams. So some of you might be aware of this. Those of you, I realize that in undergraduate education, we're not doing this. There's still the old pass fail is still coming through with us. But I know in postgraduate education, the college is very keen to get all of the college exams to have proper standard setting. And a lot of them will be criterion referenced standard setting. So there's lots of different methods, and I'm just going to use you one method because it's going to help us think a little bit about competence. And this is the concept of the borderline candidate. So to be able to decide where should we set where at what point do we say somebody has passed, we have to understand what's the difference between somebody that will fail, but we will definitely fail this particular activity. So think again about the driving test and what kind of person would definitely pass. And then there's somebody that's on the borderline. And if you think of the cut rate, the 50% pass rate, it's the person who scores 50% on the test, for example. So what we call a borderline candidate is somebody who's not clearly competent, but not clearly incompetent either. So from an examiner point of view, you can think to yourself, what's the minimal standard of performance we would accept as safe and competent for the stage of training for this particular activity that I'm observing? So how do we use this? And the borderline group method is quite an easy method. And you don't need very fancy statistics. You can use fancy statistics, but if you don't want to use fancy statistics, when you do your OSCE, so you've got 10 stations in your OSCE and they've got their normal checklist where you check off how they've done. Then on that same checklist, you ask the person who is observing this consultation, not consultation, OSCE station is the word, which of these, and you can have different ones, but definitely it will have a global rating. So fail, borderline, pass, and you can have good and excellent, or even just a highly performing, or whatever you have. If you also want to set what is my A candidate, for example, or what is my, not A is not the right word, my top performers, or my distinction, sorry, that's the word, distinction candidate for this particular station. So the borderline is, so basically when you're sitting at a station and you're watching, and again, we're talking about that intuitive almost sounds so subjective, but we have what our intuition does is it pulls together all of our expertise on a particular field, everything we know that can happen, everything we're seeing and how this student in front of us is performing, and we can by watching them we can imagine, okay, do I think this is a pass? Do I think this is a fail? Oh, actually this one is right on the edge there, and that's what we call our borderline candidate. So what everybody does is they all actually mark which one of these candidates they are. And so at the end of your exams, you can then go and see what is the percentages for that station that all the borderline candidates scored. So say you've only got 3 borderline candidates and one of them scored 56% and one scored 57% and one scored 58%, then you might make 57% the pass score for that station. There are some interesting regression analyses that helps to find the relationship between the global ratings also for that particular station and how everybody else performed, and you can do all kinds of interesting statistics, and that makes it gives it a little bit of a higher level, obviously also helping the more candidates you have that's actually did that particular OSCE. But on a very basic level, it starts giving us a little bit of an idea of where our competency threshold is for each particular station, and that might end up setting your pass rate for that entire OSCE. So maybe before we go on into taking this into entrustment, I've just thrown some very heavy academic concepts to you. And I also think everybody has arrived. Oh, look, and we're not a too big a group. So what I'm going to do now is I'm going to ask everybody to introduce themselves. We said last time it would be nice for people to introduce themselves. And now that everybody's arrived, we can do that. So just would love to hear where you are sitting and which discipline you are from. And then at this point, we can check if there's any questions around all this reliability, validity, borderlines, and all of that I've mentioned. And it might be interesting to hear if you've ever used a standard setting method like this in an exam setting, if you've been exposed to that. And what I think I'm going to do is I'm just going to go down my list. So Bayanda, can I ask you to unmute and introduce yourself?
Hi, my name is Bayanda Mbambisa. I'm an ophthalmologist based in Gqeberha. Any
Great.
other?
And have you ever used this kind of standard setting in anything, Bayanda?
I haven't, but I do have a question that I'd like to ask
Yes.
at the end.
Okay, we can. Okay, great. I'll come back to you with a question. Great. Frank, do you want to quickly introduce yourself?
Hello, everyone. My name is Frank Makosa. I'm a medical physicist. So, yes, nice. So basically, most of the things that we do as medical physicists with regards to training, we don't really end up reaching the stage of analyzing and checking the pass and the fails of students, but we assists various fields like doctors that are in radiology, in nuclear medicine, as well as radiation oncology, with radiation protection and physics data as we teach them along. The assessments are done at university levels. So I'm also in Rebecca.
Okay.
Yes, thank you.
Very nice. Welcome. Very nice. Carla.
Hi everyone. I'm Carla. I'm a peds oncologist, but I'm based at Free Hospital, I suppose representing the peds department. Peds oncology, I'm also involved with exams, but we do exams in a different way there. But yeah, that's me.
Great. Milind? Milind, we can't hear you yet. Oh, there we go. You're slowly coming through. You were very soft.
Sorry, I was battling to unmute myself. So I'm Milind Chiknis. I'm a consultant pediatric surgeon at Frere Hospital, East London, and de facto academic head of the Department of Pediatric Surgery at WUSU. I have been examiner for the Pediatric Surgery Fellowship examination for many years. I was also a moderator for the second semester, and I have experience of using ENGOF standard setting for SBA MCQ questions. So I would like you to just explain to the group how does the ENGOF standard setting works. Thank you. And
Right, yes. Thanks, Milind. You probably know more about ENGOF than I do, but ENGOF also uses the borderline, please correct me if I'm wrong, the borderline person principle. So in the diploma of HIV management, because I've got 350 people who write at a time, I can use Cohen, so we can use pure statistics. But if you've got a much smaller group of people, even writing a written exam, you can't use that to decide how difficult your exam is. So you have to go through each question, and a group of experts, you as those who will go decide what the borderline, if the borderline candidate will get that question right or wrong, to be able to help set your percentage for your paper. Do I have that right, Milind?
That's absolutely correct. Usually we have 5 to 6 candidates per exam, and what we do is either on the afternoon of that exam or latest the next morning, we meet minimum criteria is 10, but quite often we have to just make do with 8 consultants from different units in the country, and then we go through exactly one question by one, and we have to give either 1 or 0. 1 is that we consider that a borderline candidate will be able to answer the question, and 0 is that a borderline candidate will not be able to answer the question. And then at the end, an average is taken, and then that average represents the standard set mark for that paper of that examination. So it was quite difficult for us to make the registrars understand that if the standard setting is high, that means the paper is easy. If the standard set was low, that means the paper was difficult, because some of the standard was set at 67% and some of them 63%. But they still failed. So it was explained to them by the chairperson of, we have a separate committee for the SBA MCQ questions, and these meetings are recorded. But you know, the candidates always like to feign ignorance about what doesn't suit them. So that is how, but now what we have instructed clear the CMSA staff, the candidates must just get the final corrected mark. There should be no ambiguity, standard set mark, etc. should not come into their final mark sheet. So thank you.
Yeah. No, it's yeah, we've had the same problem with the HIV diploma. So my Cohen method normally sits my pass mark around 59 or 60%. Pretty much every exam is exactly the same, which is quite encouraging. But now you've got the kid who gets 58% and then feels very hard done by that they've been failed. So yeah, Milind, we've also had to do a lot of explaining. And then the university sometimes wants a score that relates to that 50%. So I know the college was also then giving people a university adjusted score. So if you were using 50% cutoff, then a 59% translates to a 47%, or I don't know, but it does. It confuses students incredibly. And I think it's that old mindset where we hold on to the little number that I got on my paper, therefore now tells you how competent I am. So this borderline candidate is quite helpful to remember, because when you're also doing WBAs, it's a little bit, your standard is if you translate the borderline into entrustment decision, is this person safe enough or not safe enough to see patients like this in the future independently, or whatever your level is. Nancy. Nancy, are you able to unmute and say hello quickly? Let's go on to Tozama. Prof. Tabula, do you quickly want to introduce yourself? I see the video is coming on. We can't hear you quite yet.
Hi, good day. I hope you can see me. Tozama Tabula from Internal Medicine in Tata. Yeah, thanks for an inspiring lecture. Yeah, I think for our undergrad, we've got a clear pass or fail based on a cutoff of 50%. And then for the postgrad, which is through the colleges, we use the Cohen method. And actually,
Okay.
when we're explaining the borderline group method, I somehow thought the concept is the same, so to say, in the sense that you aggregate. Is it an aggregation of the score, and in which 2/3 of the candidates would score and then decide on the pass mark based on that? Yeah, something along those lines. Yeah. Yeah. I had a question as well, or I rather have a question. I'm not sure whether to ask now or later.
Please give it to us now, then I'll make sure we put it in somewhere.
Yeah. Okay. It's basically it is, what is this entrustment? I'll explain maybe to try to make the question clearer. If I've got this first year registrar, is it saying I want you to be a specialist in 4 years and this is the level in which I expect you to be? So I always measure you against that level until you reach it. Or is it something that says, I expect a first year registrar to be at this level, and therefore if you're lower than this, I will not score you. But if you're at this level as a first year registrar, I am satisfied, I can give you a 5. So is it something that says all first year registrars are likely to get 1, 2, 3 at best, and by third, fourth year, they should be going to 4, 5? I hope I'm clear. That's
No.
what I was.
Wonderful question. It's one of those questions that you've been planted to ask that question. So thank you very, very much. So very important is that the entrustment levels has got nothing to do in terms of where the registrar is within their training. The entrustment level has to do and we'll look through that. We're going to do an exercise that's going to help illustrate this. But the point is to see at that moment with how well they are doing with what I've just observed, how well can I trust them to do that in the future? So yeah, let's use the lumbar puncture as an example. So if you've got like my guy who's come from internal medicine and he's really good at lumbar punctures. He's done loads of lumbar punctures and he's a wizard lumbar punctures. And actually I got him to, he was doing, measuring the pressure. We actually got him to make a video for the interns on how to use a drip thing to measure the pressure. So when I do an entrustment decision for him on his lumbar puncture, and I have to decide with lumbar punctures, just for that question, should he be only observing? Should he have somebody next to him scrubbed up? Can he do it, but I must be down the corridor? can he do it, but I can be at home, or can he actually teach this? So that's the only question I ask for what I'm looking right in front of him in terms of that activity in the future. And obviously we're thinking within my department. So within my department, within family medicine, what level would I give him? And so for him, for example, he might be a first-year registrar, but for an LP, he might get an entrustment level 5. So quite often when we talk about recognizing previous learning, this helps for some registrar or a MO who's been in your department for a very long time, might be at a really high level of entrustment, and you already know that guy can do this. I don't even have to worry about that. And he might even get an EPA written off early in the year. But we're going to look at some exercises of that in a moment, but that was an excellent question. Just to show how the Cohen and the Angoff compares. So the Cohen method is actually norm referenced. So that's where we use the 2/3. So you would look at what's the percentile. So when I do the diploma standard, when I want to set my pass rate, I will look at what is my guys scoring on the 90th centile. So where's my 90th centile sitting? You can sort of see on a graph where, what is that? What is my 90th centile mark? So say it's 88%. And then you would look at 60% of that highest, that your 90th centile, you get a cone 60, you get a cone 65, and then you add or plus standard errors of management. I know it all gets very complicated, but you're using that mark of how your top performing students are doing to give you an idea of what the pass rate should be. So we're using the norm of the group to decide, and you can only do that if you've got enough people who's writing the exam. So that's why we can do it in internal medicine, and we can do it in diploma of HIV management. The borderline method is actually completely different, because the borderline method is looking at, like, for example, with the Angoff, you would look at each MCQ question and you would decide, would a borderline candidate fail or pass this question? And a group of experts, not a group of statisticians, make the decision. So rather using your stats from the exam to give you a pass rate, a group of experts on their own understanding of competence and what the borderline candidate looks like makes that decision. So very, very different ways of looking at standard setting. And again, each of them has got pluses and minuses. Like Milind was mentioned, if you want to do the expert method, you have to have enough experts in the room, and you have to have the right people in the room. So that can be a challenge. And so you will look, depending on your exam and what you're trying to, for what kind of standard setting you want to do. But we do want to get away from that 50% cut rate. Yonela, do you want to introduce yourself?
Hello, I'm
Yes.
Yonela Bonzo. I am from obstetrics and gynecology in Kabeja. This is all still quite new to me. I'm a junior consultant here, so I'm learning. Thank you.
Your brain's going to be whizzing at this. You're going to start asking some difficult questions in your meetings about exams. Thank you. You're very welcome. Nancy, are you with
Thank you
us?
very much.
Nancy, are you able to unmute? You can also put something in the chat if you're having trouble with. Okay. We'll get back to her in a moment. And then I've got two co-facilitators on the call today. Emma, do you quickly want to introduce yourself?
Hi, I'm Emma Wynne. I'm a gynecologist at Frey Hospital in East London.
Okay. And Emma, your experience in terms of doing standard setting for exams?
I haven't done much in the way of examinations at this point either, so I can't say anything to that.
Oh, that's right. Yes. And Graham is our other co-facilitator.
One second there, I had no idea that I was a co-facilitator, but
Oh, you're not? Oh, no, you haven't done the training. I am so
No.
sorry. You're not a co-facilitator. I will put you down
No,
as
this is my
you
first
are
time.
going to be a co-facilitator. Sorry, Graham is
Okay.
one of my colleagues in teaching registrars. So that's I see him as my. Okay, sorry, Graham. Would you like to introduce yourself as a participant?
So I'm Graham, and we're definitely a participant, not a co-facilitator. I'm at in family medicine at Isilimela Hospital near Port St. John's.
And have you had any exposure to standard setting, Graham?
None at all.
Okay.
So it's all quite new and interesting.
Yeah. Great. So that's got us in the right. Bayana, do you quickly want to ask your question?
Yeah, it's regarding this whole standard setting, and
Yes.
how does it then relate to the old concept that we had of a Gaussian curve, where you expect the majority of candidates to do well, to pass and do well, and then you'd have very few who are getting distinctions, and you should have a few who are failing. Or is that sort of thrown out the window?
No, so actually standard setting, if you do standard setting right, it should create that curve for you. So for example, the Cohen method uses the curve. So your Cohen method creates, so the way the bell curve works is it's a natural phenomenon. It's like height. If you were to measure everybody's heights, there's always a majority in the middle, and then there's always a few that's very tall and a few that's very short. And that's the reason why we do things like randomization and huge samples, because this is lovely magic thing. If you've got huge amounts of numbers and you're looking at any specific qualifying feature, whatever it may be, you're always going to end up with a bell curve. And you can use that bell curve then to start understanding. So the question always is that, so for example, if you've got a very difficult exam or you've got a very easy exam, you're not going to get a proper bell curve. So if your exam is extremely difficult and you've got a 50% sort of cutoff rate, you might have a lot of people who are going to be failing that exam, or your bell curve might be sitting on the wrong side of your failure rate. The same with if exam is extremely easy, then you're going to end up sitting with your whole bell curve sitting on the right-hand side of that particular 50%. So the challenge is how do we create an exam that is actually reliable and representative of the actual skill of our students? And this is where the standard setting comes in. So the idea of standard setting is exactly to do that, Bayanda, that we don't end up with something like a random 50% that is not actually speaking to what's happening in the bell curve. So your borderline student is helping you to sort of identify around which pass mark does this exam need to be centering, depending on if it's very difficult or very easy. I hope that makes sense. It's a what we're going to do next is start to now start thinking in terms of how does this now translate from an entrustment level, from competency to entrustment level. So this is just a reminder of these are our entrustment levels. I've taken out the numbers. We're sort of getting very used to them now. We know that this middle level is the reactive supervision level. So I expect my registrar, I should be on standby for my registrar at all times for those kinds of activities, either whether it's at home or whether it's in the theatre itself. And then at some point, my trainee is going to be able to actually run my clinic even if I'm on holiday. So that's your two. Usually for most of us, it's about when do I decide they get to this level. So I was a little bit playing around with how we intuitively might use some information to help set the level. So for example, let me actually show you the examples. So it depends a little bit on how well and confident they are on the topic and what you've seen of them in practice. So I'm going to show you a couple of examples, and then we're going to try and develop our own examples in our own settings. So for example, when we talk about, so I'm going to give an example of my setting. So I've got an HIV clinic as part of Ward 5. It's sort of an advanced clinical care clinic, we call it. It's not very busy, but we've got some patients who come in with HIV, but quite often third line or very complicated patients with various other comorbid conditions. And we're actually using it as a training opportunity mostly. It's not doing a huge amount of clinical care. So in terms of our 5 levels, so remember for entrustment level 1 should observe only. I have medical students that come through that unit, and they don't even know their basic HIV guidelines very well. They usually know all the pathophysiology, and we're still busy teaching them the HIV guidelines. And so I'm happy for them to sit in on consultations, but I only trust them to observe a consultation. So if I was to do a WBA on a student and see where they're at in terms of being able to take all the appropriate information that you need when you see somebody with HIV, a 5th-year student or a 4th-year student, I might no, I need you to sit in and observe. That's all I'm managing to trust you to do at the moment. Then we've got interns that come in. The interns, HIV guidelines are not very well taught in regional hospital settings. So actually most of them really, they know the basic guidelines, they've seen TLD, they actually have never heard of lopinavir, ritonavir, because that was a different era apparently. And so what we've done with that clinic is I ask my interns, they can see the patients on their own, but they have to discuss each patient with me. So I trust that they can do a history and an examination, but I don't trust that they can do any decision-making on those patients unless they're first discussed with me. So that'll be the same for a surgical procedure. I'm happy for them to do the cesarean section right now, but I need to assist. But I'll talk through surgery in a moment, actually. I've got a separate slide for that. Now we talk about the indirect reactive supervision. So my first year registrars all come for a little tour through they spend a couple of weeks or a month as part of their infectious disease in the HIV unit. And they already should have quite detailed knowledge of HIV. They should have already been managing quite a lot of patients with HIV before they even get to us. And so I'm happy for them to see their patients, and they can come and ask me if there's something not sure about. But there is basically an understanding that any area that they're unclear about, they ask, because they are still within a learning situation. So although they see patients independently, I'm in the same unit and they're going to come and discuss with me whenever they need to. Then I've got registrars who actually then do their diploma on HIV management. They actually know a lot of, they've got a very detailed understanding of HIV. And so when I'm away on holiday, I can actually put that registrar in charge of that clinic and even be supervising some of the interns that's going through that. So that means I'm now at the level of they can act independently. Obviously, if they see a third-line patient and something is odd, they can still call the infectious disease consultant for advice, just like I would do if I see somebody, but I don't need to be on call for them while they're doing that work. And in the fifth level, for example, that will sort of be the level that I am at. I am now already at the level where I've the convener for the diploma on HIV management for many years, so this has become part of my expertise. And so my level is a level 5, and I can actually train staff in the department on HIV. So I'm hoping that's giving you an idea of how we translate what you're able to trust somebody to do. So that comes back to that lovely question from Prof. Tabula earlier, is that you're going to look the person in front of you in terms of the speciality that they're in. So all of these things play a role, but as they are in my theater or in my OPD or in my emergency medicine room, what level of supervision do I trust them, or without what level of supervision do I trust them to work? And trust is, again, that magic word that encompasses so much. So I've tried to do this also using a procedure as an example. So if you're thinking in terms of a cesarean section, so now you might have a new registrar in Ops and Gynae or in family medicine, and they've never done or seen a cesarean section. That would be more like an intern. And so at level 1, they might be assisting a senior in theater when they're doing a cesarean section. Level 2 now, they've done they've assisted, they've done a couple of Caesars, they've learned how to do some Caesar, you've watched them doing a Caesar, they're sort of there, but you're not yet happy for them to do Caesars without another senior assisting. So they can do cesarean sections, but they must have a senior doctor who's the first assistant. Then you might get to the point where actually you've observed there, you've been assisting them a few times, they seem to be able to do a nice straightforward cesarean section, they're quite confident, and you're quite happy that they can do like the elective list, for example, but they must be a senior in the hospital. And then there's going to come a point where you're going to go, I'm happy for them to I'll be at home and they can be on call and they can be first on call for the cesarean sections. And I'm happy that they can manage pretty much any cesarean section that comes through the door. It's obviously always a scenario where you might need an expert, but they can pretty much work independently. And then, of course, the 5th level is the level where our highest experts are in terms of actually teaching these skills. So I'm hoping it's starting to give you an idea of how we think of these two different things. So we are a small enough group that I'm not going to break us into breakaway rooms, because I think we're going to, I don't know, I'm happy. Emma, I don't know what you think. We've got 7 participants.
Yeah, I think it makes sense for one group.
So, because that'll be quite nice for discussion. Bayanda, yeah, please go ahead.
I'm just not clear on level 4 and 5, because you seem to imply that a registrar can never get to level 5.
Well, they can. No, they definitely can. So for example, I had a registrar who he wanted to do radiology, and then he specialized in family medicine, and he did a bit of radiology before he did specialized in family medicine, and he is an absolute ultrasound whiz. So he is like, I think, one of the leading ultrasound guys. I think he knows more sometimes than the radiologist. So he scored a 5 very early on during his registrar training, and he's been training. He did his MEd on ultrasounds, and he's been training interns on how to do ultrasounds. So for ultrasound, he would get a level 5. So you might also sometimes have a registrar who's also been in your department for a long period of time, and he's actually, maybe let's take cesarean sections, and the absolute wizard cesarean sections, been doing on calls in your department for years, and now you're going to get to a point where he's actually able to teach everybody else, and you might give them there for a level 5. So there's and so some people also can be level 5 already in year 1. All you want to think about is what level of trust can I do? And sort of, this is our top experts in the field. This is like when you get stuck, who's the person that you call if you're stuck on a specific thing?
Yeah,
Does that make sense?
That concept of expert,
Yes.
because for me, I think, some of our registrars are level 5 because they're already supervising juniors. So the senior registrars often supervise the juniors. And
Not
they're
so
very
much
good
about
at what they do.
Yeah.
But they, I wouldn't go as far as saying they're experts in their field, but I trust them with supervising juniors.
Okay, now I see what you're saying. Yeah, so the trick is here that you are I like the word expert. So we also need to get the wording of these levels better and better. So yeah, because that provides our oversight. You're right. Quite often we would get older registrars to provide oversight, but so I agree with you. You're looking for that level of expertise where they're such an expert in that area that they teach it to others, if that makes sense.
Okay.
Yeah. So, but yeah, so when you're looking at the registrar, it's not just about, okay, I'm willing to get him to teach the intern how to do the cesarean section. You're actually looking for another level before you're going to give them that level 5. Thanks for bringing that up, because we're busy trying to get the wording right of these different levels. And you're right, that could be deceptive, that word oversight of junior doctors. I'm making a note. Okay, cool. Nice. Great. Thank you very much. Great. So the exercise, what we're going to do